Hello and welcome to this webinar. This is the third in our new series called Digital Technology Innovations in Healthcare. Today we are discussing structuring healthcare data with AI for smarter decision making. Before we get started, a few housekeeping tips. We'll be taking questions from the audience. So please post your questions in the chat box and we will answer them towards the end of the webinar. Also, we'll be sharing this recording of this webinar as soon as it's made available. And you can also follow us on LinkedIn and sign up for our newsletter to keep updated on new episodes. Without further ado, I'd like to introduce you to our guest today, Dr. Kristen Engelen. Dr. Engelen co-founded RxLive, a value-based pharmacy solution that includes AI/ML analytics, clinical pharmacist services delivered via telehealth, and a cloud-based SaaS platform designed to deliver comprehensive medical management services. Dr. Engelen, thank you for joining us today, and I would like to introduce yourself and tell us a little bit more about RxLive.
Well, thank you, Shibu, for that lovely introduction. It's my pleasure to be joining you today. During my tenure with RxLive, I had the pleasure of working with the Cabot Solutions team and did a lot of exciting things. So thank you for having me. So a little bit about myself. I am a clinical pharmacist by background and training. And over the course of my career, I started in retail pharmacy, so direct patient-facing care. About 8 years ago, co-founded RxLive, which was a telehealth solution for delivering clinical pharmacist services for improving medication-related outcomes. And during that time, we had a strong focus on ensuring that the right patient at the right time had the right pharmacist intervention. So today we're going to be talking a bit about what that looked like in the world of analytics and artificial intelligence. During my journey as the co-founder of RxLive, my functional oversight included clinical and care coordination, operations, clinical informatics, product management, regulatory and interoperability strategy, corporate compliance, clinical quality, and a variety of other executive functions. But the thing that I'm really the most passionate about is clinical interoperability, because I really believe that there's this opportunity to drive incredible improvements in both patient outcomes as well as the provider and healthcare provider experience, reducing the level of effort required for documentation, and ultimately being able to share that information back into an exchange, a safeguarded exchange, will really help to drive and is driving quality for patient care forward.
One of the big things in this whole process is standardizing prescription medical directions, right? So, and what inspired you to focus on that specific aspect?
So medication directions for use often lack standardization. And the problem with a lack in standardization in any area, whether we're talking about healthcare, banking, inventory management, is that there's lots of opportunities for user error. And medication directions for use is one of those areas where we see a lot of directions that are insufficient for use. We see inconsistent formats and abbreviations across units and prescriptions. There may be ambiguity in the directions for use, causing patient confusion. There can be errors related to the incorrect directions being translated. There can be misinterpretations. And then if you think about the standard elements, if it's not standardized, it can't be shared interoperably. So what that results in is the lack of sharing between healthcare system and healthcare system, or pharmacy and pharmacy, of patients' medications and their directions for use. So particularly during transitions of care, there is data that could be shared more effectively to ensure that patients are using the medications and being prescribed the medications and in the way that they were intended to be by the initial prescriber.
When I used to go to doctors, many years ago, they used to scribble something on a piece of paper, right? So that was a prescription, and we would take that to a pharmacist. So things have evolved a lot now. So they're typing in the prescription into an EMR system and so on. But even those typing, it's not fully understood, or there could be ambiguity in that, right? So. Um, can you maybe tell us a little bit about the free text prescription directions and why the standardization is important?
Yeah, absolutely. And to your point, data has become digitized in the past decades, and we've been moving forward towards EHR adoption. It's certainly increased the number of electronic prescriptions that are utilized versus the older handwritten
Uh-huh.
prescriptions. In the United States, many of the individual states actually require e-prescribing for controlled substances, for example. And that's really where we've seen the impetus to move to e-prescribing that's um, required. For standardization of medication directions for use, this particular standard is handled by the National Council for Prescription Drug Programs, or the NCPDP. And the standard actually
Yeah.
includes 106 different data elements. And because there's 106 different data elements, there's quite a few opportunities for misinterpretation. So for example, there could be data field mapping errors where taking one tablet every 12 hours is misinterpreted and mapped to the frequency field of taking one tablet every 1 hour. Patient could receive an overdose in that example. Directions for use could also accidentally be shortened, missing data if there is a limitation on how long that field is allowed to be in the electronic health record. And there could also be a lack of frequency mapping standard based on the spoken text. So every other day versus every day could be a problem that we needed to solve for. What that ends up being then is an opportunity for us to use subject matter experts like pharmacists to help map the data from a data set to the
Mhm.
standard. So the way that we actually executed on creating those standards for medication direction use was by taking an initial sample set of de-identified medication directions for use of about 100 directions for use, and then running them through a large language model to identify what the computer could do independently without any instruction. Then from there, using the standards, the pharmacist team was able to say, okay, this makes sense here, this doesn't make sense here. So you incorporate rules as you go along, but ideally you don't want to use too many rules. So that's a little bit about the problem and how we
Mhm.
started to approach structuring the project.
So you touched on the LLMs. So can you tell us a little bit about how that helps transform free text directions into structured data?
For sure. So the the thing about LLMs is that they're based on billions of data points of language, and it's able to interpret both the intent and the semantics of speech, so human speech.
Mhm.
And because it's able to interpret the semantics, it can take things that are missing, like if there's words that are missing, and it can deduce that it is missing that information and then add it. It can also map each of those words by tokenization to the correct data element that it's meant to represent. And that's really where so the tokenization, and you could probably speak more to that because I am not a technical expert by any
Yeah.
means. I am a clinical pharmacist by training, but essentially helping the algorithm do its job.
So then, how do you the question of accuracy comes in, right? So I know we need high levels of accuracy. So how do you increase accuracy in this standard prescription directions?
Iterations by adding structured rules each time and identifying where there's opportunities for improvement. So looking
Mhm.
at the same 100 sets of directions and having a subject matter expert in this problem, in this example, a clinical pharmacist, but it could be any healthcare provider when we're talking about standardizing data. You need to ensure that you have a subject matter expert that is able to review the output and ensure that all of the fields map correctly, because that's really where you improve the accuracy. So the initial accuracy was around 85%, but we were able to push it with each iteration, meaning more rules created to train the model on how to interpret the directions for use. And each time we added additional rules, the quality and the accuracy improved.
I heard the pharmacists, they play the last line of defense in this chain. Um, so what is the role of pharmacists in this process? And how do they validate this text?
So, with the National Council of Prescription Drug Programming standards, so we use the directions for use standard. There's very
Mhm.
specific examples that are found in the frequently asked questions guide, which is where you can go to learn more about how to adopt and incorporate this data standard into your electronic records. And so the pharmacist used those guidance from the NCPDP, as well as, of course, their clinical experience to review all of those directions and ensure that each of the pieces of the puzzle were correct. So we needed to ensure that the verbiage was correct. We needed to ensure that the route of administration was correct, the frequency, the dose, any additional instructions for use. And even though that sounds like just a few items, we did have to go identify where there were duplications, because sometimes there's frequency that's related to daily, hourly, weekly. There's a lot of different ways that there is the same data that shows up, and it's also coded similarly, depending on if we're talking about a prescription that's intended for administration in an inpatient setting versus a prescription that's intended to be dispensed to a patient and taken at home independently. So some of the validation steps that we included were like pre-processing that included lowercasing and standardizing abbreviations. We ensured that there was consistent output for the SNOMED and FMT codes. And then, of course, ensuring that the structured fields were mapped accurately. So that increased our cell accuracy. And what I mean by that is the percentage of correct fields, as well as the full example accuracy. So the complete correctness of the entire instructions. So that was another thing that we ran into, was there's a difference between having one element correct and having the full example correct.
So coming from, I'm a layman in this area. What I understand is when a doctor might say a text, he might type in a text like "take this tablet 2 times per day orally," and we are going to take that text and create a standardized structure out of that, right? So can you explain maybe with a simple example the role of the NCPDP structured and codified SIG format in the standardization process?
Sure. So the NCPDP is the organization that promulgates the standards for all things related to pharmacy and medication. So it traditionally is the code system that's used for pharmacies to dispense and adjudicate medication transactions. It's used for e-prescribing, as well as for anything that is um, related to inpatient use for pharmacy um, dispensing and administration. How does it relate to the directions for use? They have quite a few different standards. So their telehealth
Mhm.
standards are the ones that are like the telecom, pardon me, the telecom standards are the one that's the most common. That is like a 900-page standard for pharmacy interoperability. The directions for use standard is very specific to just the directions for how medications can be used. And it's used sometimes in pharmacy programs, but it's not required. And the same goes for electronic health records, so the medical records of the doctor's office. It can be used, but it's not required to be used. The standards that govern electronic health records are typically referred to as Health Level 7 or Fast Healthcare Interoperability um, resources. And this is the standard that has been adopted by the TEFCA Council, so the um, Trusted Exchange Framework and Common Agreement, which is
Mhm.
the relatively new agreement that was promulgated in the past 2 or 3 years. There's a lot of work that was put into it that is designed to govern a new Qualified Health Information Network standard, so a QHIN standard. That's the newest acronym in the world of healthcare interoperability.
Mhm.
So the NCPDP directions for use are compatible with FHIR and
Okay.
HL7, but they aren't a part of FHIR and HL7. They use many of the same standards for data elements like indication or anything relating to laboratory values. So the snowbed standards, the FMT standards, those are used by the NCPDP and also by FHIR. So there's a lot of acronym soup, I suppose,
Yeah.
when we talk
Mhm.
about all of the different organizations that help with standardizing health-related information.
How does a project like this use existing health information exchange frameworks like QHIN and FHIR or FHIR? Maybe tell us a little bit about the health information exchanges. What is their role?
Sure. So, following the completion of the LLM, the next step was to create APIs for pushing the directions for use back into a qualified health information network so that it can be usable. And that's really the intent of any discussion or program for interoperability. The intent is to be able to share important information about ourselves, our patients. You know, we talk about it in the abstract sense. I mean, I'm a patient, you're a patient. We all consume
Mhm.
health care. So being able to access information related to the delivery of our healthcare and ensure that we have access to share that with each of the providers that we wish to, whether that's our pharmacy, whether that's our primary care doctor, whether that's the hospital when if we're so unfortunate that we're hospitalized. You know, the intent of creating these integrations is so that people can access their information and that their providers can access their information in a easy and accessible way.
Okay. Can we talk a little bit about the mapping of the free text to standardized data? Is there some kind of pre-processing happening? What are some of the techniques in that?
Right. So I did mention some of those before, but uh, the initial testing and validation, we identified common errors, particularly complex dosing schedules or unusual abbreviations, and then
Mm.
took that to the pharmacist, said, hey, what does this abbreviation mean? Because oftentimes you'll see things that are shorthand and help us to map those to the correct data elements. So that was the first piece. Then we had to identify and differentiate similar field types. So like the frequency field type, that we needed quite a few examples in order to train the model so that it understood frequency accurately. It improved to about 85% on that second round where we were mapping to the field data classification elements. And then the final iteration was really focused on optimization, so performance optimization, to improve the processing speed, because we want to make sure that it comes back quickly so that the pharmacist can move on, and also so that we don't so that it's easier to push data back and forth. So again, that was tokenizing elements and ensuring that they were scalable for high volume processing.
When you took the solution to pharmacists, what did you hear back from them? Was there any unexpected findings or learnings when they started using it and you started implementing it?
So the intent is to reduce the amount of time spent on documentation, and also to ensure that they're that medication directions for use are complete. So being able to quickly document and ensure that you and be assured that you have all of the information that is required for interoperability, and pushing the information from the pharmacist record into the provider's electronic health record, because that was a key part of what we were doing, right? Was providing medication reconciliation and review services prior to an already scheduled patient office visit. So having the pharmacist be able to pull in from the EHR the medication history and have all of the directions for use pre-populate, and also ensure that once the pharmacist completes their discussion with the patient, that all of the directions were in the format that they needed to be. It's really something that happens on the back end. It's not really something that is visible to the pharmacist in the moment when they're providing the care to the patient, which I think is really key for a lot of these AI-enabled technologies that are intended to help clinicians. Like, the clinicians don't really care about what the data elements are behind the scenes. All they care about is being able to get their work done quickly and efficiently and accurately, and then being able to share it back. So I think it really helped with workload balancing, because they didn't have to spend quite so much time doing the medication reconciliation piece.
Yeah. They wouldn't want to know about FHIR and QHIN and HL7 and so on. That's where we come in, right?
Precisely.
And let's talk a little bit about patients. So how does that how does this process enhance patient safety and help them with medical, adhering to their prescription?
Well, it reduces and eliminates ambiguous directions. It ensures that there's consistent interpretation across all healthcare settings. And what I referred to at the beginning is really the most crucial piece, is during transitions of care. So this is this was part of the impetus. So a transition of care is when a patient perhaps is seen in the emergency department, or is moved to the hospital, or is moved from the hospital to an assisted living facility. These are what we call transitions of care in the healthcare industry. And there's a lot of opportunities for errors during these transitions of care. A lot because patients aren't able to perhaps share all of their health-related information, especially in those circumstances when they are experiencing a difficult medical event. and being able to confidently review a patient's medication history and directions for use by pulling that information from the Health Information Exchange, in this case, a QHIN. It reduces the level of effort by those emergency department workers as well as hospitalists in collecting information related to, in this case, medications, but it could be anything, right? And it reduces the amount of time as well. It improves patient safety because we know that if we are pulling it, and this is still theoretical, right? Like, I mean, this is what we were hoping to support and bring to market was information that's complete and verified by a pharmacist, time-stamped, and includes all of the required data elements so that it could be shared with confidence with other healthcare providers and institutions. The intent then is you don't have to tell the hospitalist your entire list of medications. And what we're talking about here, of course, are the more complicated patients, folks who take lots of medications that change frequently. So being able to have a source of truth that is accessible and shareable really could reduce the number of medication errors that happen during transitions of care.
Okay, so you talked about hospitals and pharmacists. Now, as a patient moves around between different hospital networks and different pharmacies, they might move addresses and so on. What role does interoperability play in this project? How does it all come into, like you said, a single source of truth? And how does it facilitate better communication across the healthcare systems?
Sure. So the United States is facing a provider healthcare shortage. It's continuing and isn't expected to resolve for the next decade. That's because we have an aging population and there's just a lot more pressure on the healthcare system. As a pharmacist, I have always advocated for team-based care. I think that when we pull in different types of healthcare providers into the patient's experience, the patient benefits, right? If they can see the doctor for their medical needs, if they can see the behavioral health specialist for their mental health needs, if they can see the dietitian for their diet needs, the pharmacist for their medication management needs, all of these healthcare providers have a role to play in improving how we live and how our patient populations are healthy. And the key to really making it work is making sure that they're all talking to each other, right? Because if everyone stays in their silos of care, then inevitably things are lost in translation. And there's duplications in healthcare delivery services. So this doctor, the rheumatologist orders labs, the cardiologist orders labs, the primary care doctor orders labs. Do we really need 3 different sets of labs for the same patient? Probably not. If the first step was to go to the Qualified Health Information Network and pull out the most updated information based on your patient's history, you wouldn't need to go do those duplication of efforts. So thinking about healthcare exchange, healthcare information exchange, and why that is so important, it's going to improve cost efficiency in the system, as well as improve patient safety and help with communication between all of those various stakeholders that are working to help people live their healthiest lives possible. This really facilitates that and reduces cost and healthcare expenditures. So that's really why I'm passionate about healthcare interoperability and specifically, pharmacy related data and interoperability, because we know that in the pharmacy area of things, as many as 30% of hospitalizations are related to medication-related problems. And those medication-related problems can be a variety of things, but we certainly don't want them to be preventable based on inaccuracies of prescribing or duplications in therapy. And that's not really specific to medication directions for use, but certainly that's the bigger picture of how will we use this information. Duplications in therapy can be seen easily during medication reconciliation processes to ensure that patients, well, that's when you would identify that a duplication in therapy could be causing harm, is during a medication reconciliation.
Yeah, I think I've seen it when moving between different providers. Sometimes there's no connection of data. They're not able to get up-to-date data from another provider. It creates, manually you have to bring in that data and so on. So this kind of eliminates those problems, and you have a single source of truth. The data is up to date. So yeah, that's great. How do you see AI transforming the pharmacy workflow in the next 5 to 10 years? What's the role of AI? How do you see it coming?
I think it's in reducing the level of effort and cost to implement standardization and changes to the way that we manage data. Because historically, well, not historically, I mean, it's organizations always have to make tough decisions about how they're going to deploy their capital, and what they want their focus to be. And that's something that every organization does at least annually to ensure that their goals are being met. So putting money into standardizing data isn't very sexy, right? It doesn't sound exciting. It doesn't, as I said before, the clinicians don't care about the structure behind the scenes.
Yeah.
They just care about whether or not they can do their job quickly, efficiently, effectively, and move on to the next patient. So I really think organizations that don't choose to adopt AI to improve workflows and improve standardization are really going to be left behind, because the speed with which we can process vast quantities of data has just is mind-boggling today. And it's really going to be about making the decisions for which type of AI do we want to implement, and at what speed of implementation, and how do we want to prioritize it, and of course, how do we keep data safe? I think that's really the bigger question, is how do we keep things safe? Because you can't just go take an off-the-shelf solution and expose it to all of your health-related protected information, right? So ensuring that de-identified data is used in order to harness these technologies is key to implementing them. But I really think that the sky is the limit. I mean, in areas like X-ray and CT scans, it's the standard already to use AI to analyze those images, because it's so much more effective and accurate than the human eye.
You said organizations who choose to use standards, are there healthcare organizations that don't use standard? I think that's a norm, right? Yeah, that's the future, right?
Yeah, I think it's about which standards. So
Mm.
thinking about the 106 different data element fields that relate to directions for use, there's a lot of duplication. and redundancy built into the systems. So it's very easy to accidentally build something that isn't compatible with another organization's EHR structure because there's so many options of how you can code something. So
Yeah.
I think that's really why TEFCA is so important, the Trusted Exchange Framework and Common Agreement, because it's another step forward towards everyone in the healthcare ecosystem agreeing to use the same framework. And by agreeing to use the same framework, you can know that when you are investing those dollars in standardizing your data to those standards, that you can be assured that other organizations are doing the same thing so that you can take full advantage of whatever information comes out of that exchange, right? Like it can't be just a one-way street. It needs to be a two-way street. You need to be able to share as well as ingest data.
We talked a lot about the pharmacy and how standardization is used in that. Can you tell us a little bit of maybe with some examples of other areas in healthcare where standardization is being impactful?
Sure. I think the area where like that's tangential but relevant to pharmacy specifically um, would be around workflow optimization in the pharmacy, right? So the way that we created these or the use case for standardizing the directions for use was really related to ensuring that our data could be shared and um, and help with the provider's workflow for medication reconciliation. But if I put on my pharmacy hat, thinking about operations in retail pharmacy or any dispensing pharmacy, automating the process between the incoming electronic health, the electronic prescription to printing the label for the prescription, that's historically been a manual process where a technician types in the directions for use and then the pharmacist reviews it to ensure that it's correct, and then a label is printed. Like we could take out all of those steps and just use AI to read the prescription and print the label. Like that would reduce the workload and it would improve the accuracy because humans humans are not as um, what's the tactful way to say this? We're all human and we all make mistakes.
Mhm.
So if we have a extremely well-trained computer, you're going to end up with a better output, a more consistent output.
What can technology vendors like Cabot and other health systems and policymakers, what can they do to help yeah, support this adoption of AI-driven standardization models?
Exactly what you're doing now, supporting organizations on their roadmap planning and implementation. And I mean, because I'm not the technologist, I'm the
Yeah.
clinician. So having a team like yours who really understands the ins and outs of what is possible and how best to achieve those integrations, like I don't necessarily, I don't have the skills to understand even, I mean, like the processing speed, right? Like I don't know about how to reduce processing speed times.
Yeah.
So having your own set of subject matter experts is also really important, right? So working with an organization who's familiar with HL7 and FHIR really reduces the level of effort required for explaining what it is that
Mhm.
you're trying to achieve.
Do you have any advice for healthcare professionals about how they could integrate AI and machine learning into their workflows?
I would say get involved with a standards organization. So the NCPDP has work groups that meet every 2 weeks based
Okay.
on whatever you're most interested in, right? Like, so you can join the patient safety one, you can join the medication therapy management one, you can join um, there's about 20 different work groups that you could participate in and share your experience as well as what your organization is trying to accomplish. Like it's really helpful to become a part of these discussions so that you know what's being implemented and you know what's coming down the pipeline. I also participate in this COIA project, which is the recognized coordinating entity for the TEFCA implementation
Hmm.
and their pharmacy work group. And I participate in the HL7 fire pharmacy work group. So um, it's really important to stay engaged with the actual organizations that are creating these standards and promulgating these standards, because that's where you're going to learn about how other people are using them, as well as how they're being implemented, and know what's even possible. So that's the first step, because you really need to understand those pieces of the puzzle before like identifying what can be solved with an AI forward approach.
Okay. Okay. And what's next for you and your team in this area of standardization and
To
AI?
be determined. I think
TPD.
TBD, another area that I think we've already successfully iterated on and continue to iterate on is identifying which people need an intervention in order to prevent a hospitalization. So,
Hmm.
that's really everyone's goal in the healthcare system is to
Hmm.
reduce risk
Yeah.
and improve patient outcomes. So, using AI to analyze um, patient data, their ethnicity, their zip code, their um, disease level burden, their medication level burden, there's all of these things that play into risk profiles. So I think that's really where everyone wants to see improvement, because that's how we spend healthcare dollars wisely instead of just hoping that we're targeting the right people and helping the right people. Developing algorithms to know in advance who's going to need more help, more attention, more office visits, um, to prevent um, worsening disease, to prevent worsening outcomes. That's really, I think,
Yeah.
where's the most exciting.
All right. I think we are close to our time, and we'd like to open the doors for some Q&A. I'm just going to check if I have some questions already. So I have a question from Sandra Susan Matthew. I might have missed this, but how do you ensure data privacy and security when using LLMs and EMRs? Is it mainly through enforcing a common standard, or are there other measures as well?
So the work that we did on this project was not within an EHR. All of this was done external to any of the PHI related data. So it was a completely de-identified data set. And then once we developed the model, the model was deployed within the, in this case, RxLive, so the cloud-based solution.
Okay. Just checking if I have more. And this de-identification of data it's a big thing in the healthcare industry, in all standardization, right? So
For sure. But it is really key to have quality training data. So
yeah.
being able to export data from electronic health records and de-identify it is really the key to being able to train these LLMs effectively.
Okay.
So,
Into is asking,
Mhm.
are there other areas in healthcare? And I think you touched on a few where you think there are similar applications of standardization. You mentioned a few earlier, but if you want to add
Yeah, for
anything.
sure. I think that there's so many opportunities to reduce the level of work that is required by people to
Mhm.
do simple things. So, one of the things that I've seen be such an impediment to collaborating with other healthcare providers is their message queue, right? They have a ton of messages in their message queue that um, it's very hard to differentiate between what's important and what's not important. So I think that would be another really, I mean, I know that there's already organizations that are working on solving this. So reading those messages, identifying which ones can be addressed in an automated way and which ones actually need to rise to the top for the healthcare provider to review. You know, a refill request is something that's really straightforward, right? You could automate that using a rules-based system. You know, has the patient been seen in the past 6 months? Check. If it's a is it a chronic medication? Check. Then you go ahead and authorize that refill, and that would really reduce the minutia of the day-to-day in the office workplace and free up providers and their support staff to work on more important problems.
Okay. Parvati is asking, are there any KPIs that is used to measure the success of AI-driven data structuring initiatives? And I'm just curious, how do customers or clients know that, yes, this solution is providing value to their business?
Yeah, I think it really depends on the use case, obviously, and who your end user is. I mean, for the example that I used for standardizing, using the standard directions for use to translate the e-prescription directly into the label for the bottle. I mean, the KPI there would be time, right? The time as well as the rate of errors. So, how often is a prescription mistranslated and printed with the wrong instructions? And it's already part of the standard in pharmacy to report errors. So when you identify an error, it's required that you have a quality improvement process in place to review the source of the error and what you can do to mitigate future risk. So like it would be very easy to incorporate that into a pharmacy's um, standard.
All right. I think we have just enough time for one more question. Ryan is asking, do you see some of the standards evolving as AI becomes more prevalent? Right now, we build standards for humans. Do you think that remains the case in the next 3 to 5 years?
I think that's outside of my skill set to answer, but I think the answer has to be yes. But I'm not a mathematician. Um, Computers are just faster and more quantitative than anything a human could hope to be. So for sure, there's bound to be changes in the way that we process information, store information, standardize information. I mean, for example, the speed piece, right? So being able to optimize how much processing power is required, like that seems like a area ripe for disruption.
Okay. Just one more question, and I promise that's the last one. Have any companies in the healthcare industry who have implemented LLMs and seen measurable profits or significant value for their implementation? This is from Nitin. Um, I'm sure there are many companies, right? Like, and from within Cabot itself, we see a lot of companies who implement LLMs and automation using AI, and standardization is driving value, and it is increasing the profitability for those companies. Uh, Doctor, if you can maybe touch on that.
Yeah, I think any healthcare conference that you go to nowadays, this is going to be a huge topic of conversation, and many of the booths in the hall are going to be touting how they are utilizing LLMs and other AI strategies to improve profitability. I mean, the sky's the limit, really.
Yeah. Yeah. All right. Hey, I think we are just in time. I would like to take this opportunity to thank you, Dr. Engelen, for speaking to us about this topic. And just as a reminder to everyone, we will be sending the recording of this webinar to those who have registered. And we will also be publishing it on LinkedIn. Do follow us on our LinkedIn company page and our newsletter to keep updated on new episodes, which will be coming every month.